I think I came away from the first weekend with more questions than answers, which I'm not sure if it's a good thing or not. But I think it will make you think about a lot of things we do here, I hope, by the end of the session today. And it just brings in a little bit of theory, some evidence, which I think is important at this time, and some questions for hopefully to take away with you. You also have homework to do before we do the second part in, what, 3 weeks' time, John?
Yeah, the 7th.
Yeah, around that time. So, what I'm going to cover today is... Oh, John, over. There it is. So, that's our learning objectives for today. We're going to look at the definition of rehabilitation and what it is, inflammation, developing exercises, and then we're going to break it down to different components. So, range of movement enhancement, i.e. flexibility, strength training, assessing form and function, and neuromuscular control and proprioception. So, they were the 4 main topics that we covered in this part 1 of that weekend. But before we start, what I'd like to do, just very briefly for 3 or 4 minutes, because I think this is what I'm hoping you're going to get out of it by the end of the session today. I'm hoping that the answers you give to this will change when you go into this. I'm really hoping that this and this will be different, that what you'll learn will change all the answers to this. That's the idea. So, for like 2 or 3 minutes, you can go in pairs if you want, or you can go separately. I want you to pick an exercise, any exercise for hamstring strengthening, and we'll say mid-stage, okay? I want you to pick an exercise, pick how you will progress it, when, like what cues you're looking for, and what cues would you look for when you're progressing the exercise, and how you progress it. So it's just for 2 or 3 minutes, we'll go into pairs, just pick any exercise, look at what exercise you're choosing, how would you progress it, and also how you regress it, when would you do it, what cues you're looking for. Just 2 or 3 minutes, just jot down a few notes quickly, and then we'll compare that to the end, hopefully. That's the idea. At the end, we want to redo it, and then see if the information that I give you changes any of your answers. So, first of all, we look at the definition of rehabilitation. So, it's the restoration of normal form and function following injury or illness. Quite a nice definition. When you're looking at rehabilitation, you have to consider all of these factors. So, you have to ensure you've got an accurate diagnosis and treatment. So, in your diagnosis, you've got to look at, say, if it's muscle belly versus tendon or a deep junction, what the blood supply is like. You have to obviously have a really good understanding of your anatomical knowledge, otherwise you're not going to get your diagnosis right, which means you're never going to get your treatment plan right. Biomechanical factors, so you need to have a look at understanding of the load. So, is it a muscle injury, tendon injury, ligament injury, bony injury, and what are the factors that influence the healing of that area. The biggest thing you have to look at here is the underlying cause of the injury, and I think we are very good at doing that. I think we always tend to look back at the underlying cause of injury, in particular it's not a traumatic injury. Trauma injuries can be slightly different, but looking at the underlying cause of the injury, is it a poor technique, is it a muscular imbalance, or weakness, or proprioception? What is the underlying cause that is potentially causing that injury? And then looking at functional deficits as well. When you look at musculoskeletal injury, when you're assessing a function, we always look at the direct result of the first injury. So, if it's an ACL, you look at the knee, is swelling, pain, restrictions in movement. Do we then go on and look at the secondary deficits of that injury, which can be more distal to the site? So, did it get calf tightness? Does that influence range of motion at the ankle? What are the secondary neuromuscular deficits that can be caused from the first direct injury? And then in our treatment plan, do we target that? So, I suppose that's just going a little bit outside the box and looking at the proximal and distal factors to the injury site and making sure that even in the early stages of that program that we are actually addressing those specific factors. Inflammation. So this is fairly basic stuff. I think we've all learned this from uni years. Acute phase, repair phase, remodeling phase. I think one of the best articles I've ever read, and that was courtesy of Graham, was the Evans article. One of you guys familiar with this article? It's the healing process at cellular level. One of you read that article? Yeah. It's a really, really good article in relation to...
Old, but it's good.
It's old, but it is good. And I think that's probably...
Philip Evans, you wrote that?
Yeah, Philip Evans. So if anybody needs a copy of that, I'll leave it here.
I'd really like a copy. I haven't read it for a while, so I'd like to revise it.
Okay, Graham, I'll do some copies of that later. I think on the course we didn't spend too long doing this, but is everybody happy with these phases of information? Because I think if we don't understand this, in particular in the acute phase, then we're never going to get our treatment right based on that acute phase. So does anybody here want to have a stab at what happens in the acute phase of injury? Does anybody here want to kind of give a little bit of a summary of what happens in those first 36 to 72 hours? Anybody brave enough to throw out a few things?
You get a response of
cellular response.
Yeah.
You get white blood cell, macrophage
Yeah.
involvement. You get lots of chemical stimuli built up. So again, they're all like signals to bring various factors. There's a whole list of factors. You want those?
Yeah. No. Right now, go ahead. Roman.
Yep. Kinase.
Yeah.
Substitute.
Yeah.
Very kind.
Pretty good. That's
Prostaglandins.
got one of them.
So that's what cellular level.
Yeah.
But you're also getting laid down of collagen potentially as well.
Yeah. Perfect. And in that acute phase, I think what we talked about a lot in the course was swelling, and why it's so important to control swelling in that first phase. Because swelling can go on up to 4 days, and they talked an awful lot about how we control swelling and why. And I think I found that really interesting because I think you always know swelling goes on for a day or two, but to 4 days, I probably didn't think it went as far as 4 days, but actually research says that it can do. And when you're looking at swelling, you're looking at obviously the cell death in the immediate area of the injury, but if you have loads and loads of swelling and fluid going out to other cells and areas around the injured site, then you're getting much more cell hypoxia and more cell death further afield as well. So I think they spent a long time talking to us about controlling that swelling. What I also found really interesting as well was, I don't know if this is all familiar to you guys, but in the inflammatory X-rays you get a lot of protein, and in part of that protein there's a fibrinogen which turns into fibrin, and that fibrin lays down on the inside surface of, like say, the synovial joints and scars up the capsule. So obviously the more swelling you have, the more exudate you have, the more of that fibrin is laid down in the capsule, and therefore the more scarring you get. I thought that was quite interesting again, kind of really understanding the theory and reasoning behind trying to get control of that swelling. Then you've got your repair phase, which is your laying down of your collagen, type 3, and building up to type 1, and then the remodeling phase leading up to 6 months. Have you ever heard of the term police before instead of rice or price? Are you familiar with the term police?
Yeah.
This is the new ACPSN push. So a couple of years ago, there's a new study came out on the price guidelines, and based off that was Chris Bleaky did it, yeah. And from these new price guidelines, did you see that? Did you go to that course?
Yeah, it's Northern Ireland.
Huh?
It's Northern
He's
Ireland.
Northern Ireland, that's right. He was given a lot of money to do research on this, and he came back with price guidelines, but in a version called the police. And the only difference is protection, as we know, the OL is optimal loading. Because what they're saying now is actually, as physios and as doctors, whenever you're casting people, are we holding people back? Are we making them non-weight bearing too long, which is therefore then not loading the structure that should be loaded in order to develop and lay down the collagen? So actually, instead of saying when you're looking at loading, you're looking at optimal loading for the structure that's injured. And again, that's where you really have to know you have to be really good at your assessments, so you diagnose the area that's injured, so the ligament, muscle or tendon.
So it's never rest, it was modified rest.
Exactly. And that's, I think, what they're trying to get across. And then the usual ice compression elevation. I think Chris Bleaky was talking about not doing, and please correct me if I'm wrong here, compression and elevation at the same time. Can I remember why? But he did say not to do two of them at the same time, but I can't remember why.
Elevation afterwards.
It was after, is it? Why not at the same time? Because I can't remember.
Because you've got a bag of fluid, and you want to bring the blood out, and then you want to then drain that bag of fluid well. Yeah, so you bring healing substances to that bag,
yeah,
and then elevation's got taken away.
Okay, right, but not at the same time.
Whereas if you've got compression, you've got no space for those healing things to come in.
Ah, gotcha. Okay. So that was quite interesting as well, because I think in the past, I was definitely thought compression elevation wasn't really a factor. And then you have to look at the factors that impede healing. So there's loads of those out there. So poor vascular supply, there's a muscle spasm, corticosteroids, which is an interesting one, the age, the health and nutrition of the person, is there muscle spasm, what the edema level is like. So you've got to consider all that too when you're dealing with inflammation. Okay, so on to this was the fun part of the weekend, developing exercises. And the whole point of this course was actually how do you develop an exercise or what do you look at when you're doing that. So they start off quite basic. We were looking at a massive document to go back and learn all our definitions for the actions of a muscle. So when you're looking at the muscle, is it the agonist or the antagonist, the synergist and the fixator? Do we look at all of those in relation to the exercises that we're giving for the joint that we're giving for and for the rehab we're doing? Which I thought was quite interesting. What's the definition of a synergist?
Co-contractor.
Yep. And fixator?
Stabilize.
Exactly. And I think I definitely maybe without actually realising what I was doing sometimes, when I'm creating exercises, I probably don't take into account enough of the synergism fixator. What do you guys think? I know I definitely don't, or hadn't in the past. But maybe you do it automatically when you're doing a set of exercises. But that was quite interesting to think about. How is the muscle working? So are we looking at concentric or eccentric contraction, or is it isometric? So what way is the muscle working, or type of muscle contraction? Starting position, where you're starting from inner, outer, and mid-range. And then when you're looking at all your muscle imbalances, I think the muscle imbalance part was quite interesting, so we looked at the difference between postural and phasic muscles, and the lists of which is a postural and which is a phasic muscle. Are you guys aware of both of those, postural and phasic muscles? Are we aware of them, or will we go through them?
Not phasic muscles.
So phasic muscles are your fast twitch muscles, they're the big force, quick fatigue type muscles. So the list that we were given was, say, tiband, vastus lateralis, glute max and med, rhomboids, and then there was question marks over like long adductors. Does that make sense to you guys?
Was there something like upper fibers of traps originally are phasic?
Yes, and then lower trap, yeah. And then your postural muscles then are your much slower twitch, and they're your iliopsoas, hamstrings, triceps, left scap, erector splenic. And again, there's then a bunch of muscles in the middle that are a little bit debatable. So again, are we considering, all of this when we are developing exercises? Then also, are we considering, so one, the muscle action which I've talked about, if it's the agonist or the antagonist, if it's a multiple action, do we look at the levers? Grade 1, 2 and 3 levers. I have learned levers since university, so that was quite interesting. Gravity, which I think we always take into consideration, buoyancy, the direction of the force, so is it axial or non-axial, and then the joint motion, so are you in sagittal plane or transverse plane or frontal plane? And again, I know it's an awful lot to take into account when you are developing an exercise program, but I think actually these are really, really important factors that we need to be getting right in our exercise programs in order to push people on, regardless of whether we're working with athletes or not, it doesn't make a difference. We need to take all these factors into consideration. And then we need to look at what factors affect our exercises. So if they've just done previous exercise, tissue temperature. This was quite interesting actually, talk about tissue temperature. They were saying that as you're doing exercises, the one they kind of did a study on was ACLs, and they discovered that the more repetitive the exercise, the increase in temperature, therefore the more AP laxity there was on the knee, which is quite interesting. So again, we're considering tissue temperature when we're doing our exercise programs. Fatigue, trunk posture.
Sorry, you have to increase the temperature quite significantly.
Yeah, I need to go back on that article. I didn't say.
Because, presumably you're looking at collagen stretches in response to heat. When you heat collagen, you have to heat it quite significantly. I'm thinking raising a joint temperature by a degree is
quite a lot.
Yeah.
It's interesting. I need to pull up the article. It's actually when I was doing this.
I don't understand the theory, but I would be very interested to know how much you would have to actually physically raise to make a significant difference.
I think we're pretty good at that, because I think we do a sort of little and often type approach with the early things as information.
But we never.
And so we're doing it for that reason. We don't want to
tissue temperature. I guess with that explained though, then if you look at say
certainly if you look at ACLs for example, that's what we exactly do with little and often early on, and then do more endurance stuff when they've got some stability.
Okay. That's good. Yeah, we do it that way. Bikram yoga. So Bikram, obviously exercising in heat, would that affect that then? It must do.
If that is true, but it takes a lot of rate. That's what I would like to know. Just what the significance is.
I'll put up the paper and see if I have it here, so I'll pull it up and we'll look at that and see.
But the more ductile and malleable the soft tissue is, the more instability and chance of laxity you're going to have. It's the same way as hormonal changes on ligaments and soft tissues too. So yeah, Bikram yoga. If you've got an ACL and they go too early, it's probably not the best time when they're doing that.
Okay. So that's always quite an interesting point, because I have to say I don't think I ever thought of it that way before this course. You also have to look at the speed of the exercise, the resistance you add, so that's the weight, or do you throw stuff with it? Position of the base of support, which will be quite interesting, and then your foot posture. And I think here we all definitely look at foot posture very, very well. And I think that is
what do you or they mean by position-based support?
So narrow-based support, wide-based support, or if you want to boost your ball or something that sort of stuff. That's what we're referring to now. What are you thinking?
Yeah, okay.
Yeah, that's what they were in the base course, so narrow, wide, step stance, that sort of. And then when to progress. So when you're looking at progressing in exercises, the signs, what signs are you looking for somebody's not coping, and then which components are not functioning. So non-coping signs, pretty easy really. Effort, pain, if they're anxious, and then during or after an exercise if there's swelling, pain, lack of range, or if there's a perceived instability. So I think we do pick that up pretty well with the signs of non-coping generally. Then you have to look at what components not functioning. So is it that the muscle isn't firing? Are they doing a compensation? Or is the exercise wrong? So I think that was, again, quite interesting because it was like, if somebody's not coping, have they got the wrong exercise? Have you given them the wrong exercise? So actually, you know, the muscles are actually firing, you've just put them to the wrong exercise. So they've given this nice 3 C's, kind of a thing to go on. So carriage, so is there a weight shift? Are they accepting their weight? So you're looking at an ACL doing a squat, for example, is there a weight shift? Control, is the movement smooth? Is it, you know, an autonomic movement, precision, performance of the skill? And their confidence, facial expression, hesitation. That's, you know, I think we can see that pretty well when a patient isn't coping with that. This is what we're going to look at, a lot of this sort of stuff. So mobility, endurance, strength, speed, power, skill, proprioception, and then sports specificity. That's kind of stuff I'm going to cover now into, again, bringing it to these programs. So the first thing they talked about was range of movement enhancement, i.e. flexibility. Nice little definition there. I'm not going to read it out, it's quite a nice definition that they had. That again is something to consider. Excessive mobility in one area of the body must not compensate for poor mobility and or lack of strength in another area. So is somebody increasing their lumbopelvic mobility to compensate for a tight hamstring? Or is there excessive, you know, pronation of the scapula compensating for limited trunk rotation? You know, with golfers, you know, doing the class, you can definitely see a lot of compensation for trunk mobility. I'm sure tennis, you see loads of it. I don't know about athletics, any kind of, you know, anything interesting you see with legs, like compensations for a tighter weak muscle. Do you see like increased lumbopelvic? Do you see a lot of tight hamstrings with that increased lumbopelvic stability? Yeah. So again,
it's always anatomy traits, isn't it? You know, tight wrist or effectively opposite hip.
Exactly, and all your fascial planes and stuff. So it's
increased mobility of the SI.
Yeah. So it's quite good. Terminology. This was a big debate we had actually on the day. There was, what do we say when we're saying do a warm-up or do, you know, a stretch or do mobility? What do we actually mean when we use those terms for our clients? So mobility, which is your facility of movement. Stretch is elongation or linear deformation that increases length. And there's a very big important difference between stretching as a part of a warm-up and then as a means of flexibility. So that's a really, really significant factor, and I'm going to get into that in more detail in a while. Different types, so your static versus your dynamic. Again, I'm going to kind of fly through this because we've got loads to get through. Flexibility programs. Are we looking at mobility exercises for the joint, the muscle, or the neural tissue, or all three? You know, are we targeting each of those? And I think over the weekend, the biggest thing that came out for all of us was the neural tissue. And do we actually address mobility exercises for neural tissue as a part of our warm-up and cool downs and stuff like that? Do we integrate that as a part of our normal training program? And most of us there didn't. Is it specific to movement and range required by the athlete? Needs to be under the control of the athlete, so all flexibility programs have to be under their control. And exercises should not involve unstable starting positions. Now, who here has done calf stretching off a step? Me? Yeah? And I never really thought about it before, but if we do calf stretching off a step and they're not holding on, they've already got muscle tension in the calf because they're unstable. So it's defeating the purpose. So thinking about our stretches, and you know, you're at work, you're trying to get people to stretch at work, or hang off the step, but actually are we telling them you need to hang on so you've got a stable base while you're in those stretch positions?
Doesn't it depend doesn't it depend really on what you're trying to gain out of that? Because if you actually try and improve the stability, that's exactly what you should be doing. So,
yeah. I suppose, and again, that's about working out, are you trying to increase stability or are you trying to get muscle length?
You wouldn't start on there, is what you're saying.
Yeah, exactly. Joint mobility, they talked a little bit about the benefits to articular cartilage. I wanted to ask you actually, because at the Masters tennis, where the older athletes are, do you guys do range of motion pre-warm-up? Do you know? Yeah? Do you do that for all your tennis players?
Yeah, and there was a laser, that's their stretch.
And that's your stretches. Because we were talking about the course, so we're saying that actually a lot of older athletes should have a regular full range of motion, non-weight bearing joint stretches in order to improve articular cartilage, just so you get the synovial fluid moving, which is quite interesting. Then I taught at the Masters Tennis, because I know you guys do a lot of that full range of motion stuff. Do you do that in athletics, Claire? Do you do like kind of full range of motion stuff, kind of pre-warm up with athletes?
Depends on the athlete, but yeah, some.
Okay. I'm just going to move on from that actually. Literature, debate, well, so much evidence out there, I know that's really conclusive. Some say that stretching doesn't reduce it doesn't reduce injury, but for some studies it did reduce some of the post-exercise soreness. But again, there's really not like any conclusive evidence to say that stretching pre or post-exercise actually changes statistics for injury or soreness, which is, I think we all probably know that anyway. The literature that's out there at the moment, McNair says a 20 to 30 second stretch is optimal, and the greatest reduction in the torque is in the first rep. So giving people reps of 5 or 6, some of the research is saying actually isn't important. It's about the first 1 or 2, because by the time you get to after a second one, you're losing the greatest reductions to that resistive torque. And they're saying anywhere between 20 and 30 seconds. There's another study that said 45, but I thought it was quite interesting with the greatest reduction being in the first rep. What do you think on that one?
I would agree.
Yeah.
I would say 2 or 3.
2, yeah. And how long do you guys stay to hold them for? So I said 30 to 40 seconds. That was what I have been saying until this.
25, minimum 25 seconds.
I was going to say 20, 30 actually.
20 to 30, yeah. But again,
that paper there isn't, it was slated because it going through very good quality stretches.
that's right, yeah. Again, all the research out there in relation to flexibility is a bit crap. But that's what the Daisy said to us at the weekend. And if you look at it all, a lot of it's contradicting each other all the time as well.
I hardly ever get them to do, hardly ever say to them 30 seconds. I'll say to them for them to feel what they've changed. So it's till you feel that there's a change. So that might be 30 seconds.
Okay. But you don't put a time out per se. Do you give them a number?
No, which sometimes they get a bit frustrated with. Give me time.
That's a good point, because most people with everything you're teaching here is really down to the individual and how much they understand.
Yeah.
And if they don't understand, then they need to be paid by numbers almost.
Yeah.
Otherwise,
And I suppose it's good with the paint by numbers. It's quite good with some of the research. At least you can back up some of it with the paint by numbers group of people. Like if you've got your good athletes who can feedback to you, it's quite nice. And this Kibler study, again, was slated for some of his methodology, but did say that it wasn't actually the number of times you stretch per day, but it had to be over weeks and months rather than per day. So I think that's something that we tend to focus on here a bit as well. Stretching to improve flexibility and warm-up doesn't happen. You're not warm enough. You have to be really, really warm in order to actually improve muscle length. So they talk about doing actual flexibility work mid to end of session and in between each set of reps that people are up and running. So if you're working in a sports environment, you need to look at, if it's an indoor or outdoor environment, the clothes that people are wearing in order to keep the body temperature up in order to gain that flexibility.
So if you're in a class setting, then they're saying you don't have to bother with a warm-up. But I mean, you don't have to bother with a stretch, like they say.
Yeah, they're pretty much saying doesn't have any effect on flexibility, but I think it's a psychological thing. Yeah, it is really debatable. And I think there was a study done about 3 years ago on footballers, 3 or 4 years ago, where it said they did either static versus dynamic warm-up and stretches. And there was no difference in the injuries, but their performance was less with the people who did dynamic, who did the dynamic had less performance than the guys who did static because it was psychological. So there is a huge psychological component to stretching.
Anecdotally as well, you'll get more muscle injuries if people haven't stretched.
Yeah, you do.
So what does that mean?
Yeah, it's an interesting one. Again, I don't know how you can ever really prove it in the studies at all. This next thing was quite interesting. They said that when you try to improve flexibility, and you do improve flexibility, do you then immediately add in strengthening exercises for that new range? Because basically what their point was that actually most physios give loads and loads of stretching, and you improve, say, the outer range of a calf stretch, and you improve the length, and you don't strengthen in that new outer range, which is why then when people come back with niggles and sprains and strains, because we've given them all this flexibility exercises, and then we haven't followed up immediately with strengthening those new ranges. Agree or disagree?
I totally
Totally
disagree.
There we go. I totally agree.
Go on, do your problem.
I totally agree. I spent my life opening up range and then giving people the power to use it. Because most people, most of my clients, close down their range as a way of reducing their pain and then don't use it. So they have disuse, the lack of range, but you'll never get that control back unless you get the muscles functioning and all the neuromuscular components around it.
So you agree with what they're saying? Do you disagree? You agree?
I'm saying that I do that all the time.
Yeah.
I don't just do one.
I think a lot of us do.
Yeah, I agree with you.
I think
I'm disagreeing with them.
Yeah, I think at the ACPSM, I think Lynn Booth in particular was had a pretty big go about it. She felt that a lot of times that we didn't, just interesting, maybe probably not, I don't know, she was just referring, she said she didn't think
we're a
that
rehab centre, so if we don't...
yeah, who is going to?
Yes.
This is just her personal opinion of what physios do.
Yeah, I think just over time and treating people and, seeing what they've done and stuff like that. She just felt that we weren't specific enough at following up those inner or outer ranges of strength that we just given those people. So it was interesting. Methods of stretching, I'm not really going to get into this, but PNF. I didn't do PNF at uni. Who here did PNF? Because, we spend a lot of time talking about PNF.
last century.
I think it's coming back in by all accounts. It's
always
been,
it's always 10 years ago.
yeah. I didn't do PNF. Did you? Any of you guys do PNF? Do you use it?
No, Joe for a pelvic floor.
I build a hoist and slings.
We all do versions of it. It's just whether you call it PNF
It's
anymore.
just combined movement.
Yeah.
Through range.
Exactly.
Yeah.
But that's what you were just talking about in the previous slide. It's combined movement, strengthening through range.
So we did lots of, we actually was practical on that as well, which is interesting. Again, evidence for stretching. Some of this was interesting actually. They said that you're not recommended to stretch end of range prior to competing or training if strength or power is required. So weightlifters and that kind of thing, they were saying actually it decreased their strength if they stretched to end of range just prior to the competition. Decreased vault speed in gymnastics, and it decreased EMG and torque strength by 3 to 6% in max effort contractions. So again, research out there is.
I think that's really important that for athletes, that you know your athlete in that situation and you know what their ranges are, which was one of the reasons we were really driving for the screening programme for the Commonwealth Games, so everybody knew their athletes.
Yeah. So you know what their level of
And
know the sport as well.
Which is why your first question, exercise you gave us was so difficult because we didn't know that.
Yeah, sorry.
That's right.
I'm going to just skip on a bit. Strength training. So, strength training, ability of muscle to generate force. Looking at strength loss, you look at the structural and neuromuscular components to this in relation to your strength training. During the first 2 weeks of strength training, only 20% of this is structural changes. So, they're looking at the neural factors which account for significant improvement in the first 4 weeks of an 8-week training plan. And then you're looking at the different sub-qualities of strength. Maximum strength, which is your one maximum voluntary contraction, so your 1 rep max. Relative strength is your strength per unit body mass ratio. Isometric strength then is your force generated by muscle without any change in the muscle length. Eccentric strength is the max force that a muscle can generate when you're experiencing a length in that muscle. I guess you know all this, right? You all know these definitions? It's all on your slides anyway. Power then is strength and speed, the ability to generate maximum force in the shortest period of time. Reactive strength, ability to generate force on jumping immediately following a landing, so looking at plyometrics. And then endurance, ability of muscle to generate force over
Do they talk about how they measure reactive
period
strength?
of time. And the endurance we're saying here in strength is not the same obviously as cardiovascular endurance. Looking at your force production, I think I found this quite interesting because it wasn't something I really thought enough about. I think you're looking at the cross-sectional area related to the max force. So obviously the greater the cross-sectional area of the muscle, the more potential there is for force. It is related to your actin and myosin binding. So obviously the better your actin and myosin binding, so the more optimal length of your muscle, the greater force potential you have.
This is obviously not post-injury.
No, this is general.
This is just taking a bog standard muscle anywhere in the body, perfectly healthy, no problem.
Exactly.
Okay, cool.
When we were doing the course, they kind of didn't really look at pathology.
Yeah.
They just
you
gave us-
cannot tell what kind of muscle is being laid down post-injury because there is so much fat, depending on where your injury is and the type of the injury. And you can't predict that. That's what a what a lot of research shows.
Okay.
And certainly in spine does, because you can't predict how much of an atrophied muscle is going to be actin and myosin and how much is going to be fat deposition. And you can scan them 2 years later, and there's still increased numbers of fat deposition compared to pre-injury.
That's really interesting.
Yeah, it is very interesting. It's very interesting. So it's very difficult to predict. It certainly is in the spine. I would imagine it's similar for...
The reason it's in the spine is because usually people have had a long-term chronic problem with a lack of use.
Yeah,
Whereas in history, if you've been couch potato for
Yes.
years to come, it's the same problem with the legs.
Yes,
Whereas if you're an elite athlete, it's quite quickly gets the
yes, yes.
Interesting. Then obviously looking at the muscle, the angle of inclination, and the pre-stretching, so your stretch shortening cycle again, and force potential. I think that's quite interesting because obviously when we assess muscle length, it is really, really important to consider your force production when you're assessing muscle length. So a shortened or lengthened muscle, you're obviously looking at the effects on force production. So I think it made me think a lot more about actually when I was assessing a muscle length, actually what I was looking for in those muscle lengths as well. That was very interesting. When you're looking at developing a strengthening program, and I think, again, they didn't really, as I say, take into consideration initially pathology, but they were just trying to give us a general think about this stuff. What muscle group are you training? What are the energy types? Is it anaerobic or an anaerobic muscle? What's the muscle action predominantly needed? So we look predominantly at concentric or eccentric muscle action. And then what are the primary sources of injury of that sport? I think Fleck and Kramer, they're two big guys in relation to looking at strength and conditioning and the functional screens and all that. They're quite big about it. When you're looking at strength training, do we take into consideration all of the above? So the type of exercise, the reps, the sets, the load, the order we put the exercises in, the speed and the rest periods in between. Now again, I think this is probably a bit more towards the strength and conditioning side of things, but even coming back from rehab and coming back from, say, an acute hamstring tear, we still have to consider all of these and how do we justify the reps, the sets, the loads, and what order we give the exercises in. What do you think? Do you just kind of go with the patient that's in front of you? Do you have some theories in the back of what sets and reps you use? Or do you have an idea of just out of experience on the order you do the exercises in? What do you guys think?
Let's go around the room with good thing, because I know what I think.
Okay.
What do you, John?
I kind of look at the order of exercises depending on the action of muscle, so whether it's more like a stabilizer or whether you're looking at sort of a synergist and type things. And then I guess with reps, it's depending on goals, go for your lower reps, higher weight, with the sort of rest period in between, depending on which energy system you're looking to kind of hit.
Anybody else want to throw in some?
Yeah, no, I prescribe pen according to the fact that patients generally do 40% of what you ask them to do. So I give them the two most important things that I want them to do, and so that's what, and I show them what I want them to achieve, and then I go from there.
Okay.
And I suppose historically we were always taught in reps of sets of 10, and it was a little bit prescriptively poor because it was based on glycogen deposition and depletion after 10 maximal contractions. It actually takes an awful lot to do to achieve a maximum contraction of most muscles, or any muscle, so that's why we often use 10. It's just historical.
And 40%, is that what you're saying anecdotally? Was that?
No. All the research that has looked at prescribing them very exact amounts has come out with figures that patients, if they're filling in self-reports, diaries, will do about 40% of what. So there's no point.
They might do the same number of reps that's requested, but only 4% throughout the week, sort of thing.
Yeah.
So it's not like you give them 10 and then you do 4.
Right. It might be 10, but they might not do 10 max.
10, but they won't do 10 as many certain weeks.
Right.
So the 40% you give.
I think, like, because I use Physiotech for all this, I think that really helps because I do a priority list for them, I do an entire list for them, and then they can look back at the history of what they were doing, and so they maintain all their different lists from me, and when they have got a day when they haven't got a lot of time, So when I'm thinking about their strength and conditioning, I'm considering that they don't do it,
Yeah.
and therefore there's an option therefore of that's your short version.
Yeah.
This is what I'd like you to do. And then within that, I will dictate or not. So I might say 2 lots of 20, but I actually might say this is that I'll discuss with them that they're going to decide how many they're doing with this, depending on, and make them understand when they would need to stop.
Yeah, so quality and that's what quality
Yeah,
of movement and stuff.
but I'll only do that to the people that get it.
Okay. And then order of the exercises. How do we, because I don't think I think about the order of the exercise I give a patient, so I give a list and I say do them, I don't give them an order. Should we? Should we go? Should we?
Depends what the goal is.
So we say ACL rehab, or say we're, I don't know, 12 weeks down the line on ACL.
Is your goal to work them in fatigue in the period, or is your goal to work quality?
Okay.
Yeah, so the order of exercise would depend really on whether they have the endurance to supply.
Okay.
But that's why reps and sets, I hate giving them,
Yeah.
but I only give them because people ask them.
I think it is, people do need to figure it out, they need something in their head to say, do this or do that.
But certainly order-wise, they might want to know what they're meant to be doing before the exercise. What's the priority before the exercise, and then what shouldn't they be doing before the exercise, as in they shouldn't be doing fatiguing exercises before the exercise.
Okay, maybe, okay. So that's again,
Can I add something back into that list?
Yeah.
Imagery is really important. So imagery, I take the image that muscle is contracting and it's working really hard. So if I'm doing glutes, then I'll say, get them to think of a piece of steak and it's contracting and moving. And you get a much better result if you, and I tell them that. So yeah, I use that the whole time. And, I know what research says, I think I get better results as a result of it. But,
There was also some research along that line of then if you put a colour to what they're imagining, that actually gets a better result as well. Yeah, weirdly. There was quite a strong paper on that. About.
do you ask them to choose a colour, or you give them a colour?
I
I
generally
haven't
get
read
them.
that paper, so I don't know.
Yeah, I don't know. I think I'd normally get them to choose, but I actually don't know what it says on that. Yeah.
The one word on that list I think is most important is the last one.
Rest, I was just coming on to it next.
Because that's what we probably don't give enough of.
That was my literally next question. What do we do about rest?
People are just like machines sometimes. They go, well, this is what I've got from me, and this is what I do, and to do it, and I do it, and this, I've got the rest in between.
Yeah. And that's quite a tricky one, I think, to dictate as well, but I do think it's something that we have to consider. And I think at the weekend, some of the stuff they were talking about was very sports environment, like in with a team, but I think a lot of this is perfect for us here, because I think it's where we do need to dictate a lot more to.
That's really hard to dictate though, the rest,
Really
because
hard.
it's very individual and
It's
it depends on
understanding what
so
rest is.
many markers
Yeah.
of what the person's feeling
I suppose
like.
we can base it as well on what stage of recovery they're in as well, you know, pain, so, you know, I'm sure there's other stuff we can kind of base it on, but it is quite a tricky one to
This is
consider.
all good textbook stuff, but it's in reality it's very different.
Yeah, it is. Then isometric, so looking at the types of strengthening, isometric muscle strengthening, evidence for this is really poor, but what they are saying generally is it's good for early stage stabilisation exercises, so ACLs, tendinopathies, quite nice for that. They're saying you increase the reps, not the intensity. Again, the paper for this, there's a question mark on the evidence. Contraction duration 6 to 12 seconds, with total 90 seconds work. Again, they were a little bit sketchy on that, but I just thought it was quite nice to put it in there. Eccentric training then, really good for injury prevention, increase in type 1 collagen fibres, much higher strength than concentric. The force capability is 120 to 160 times greater than a concentric. And
How do you know that?
it was just some paper, an evidence paper that was done that eccentric training, strength training creates up to 160% greater strength production.
I'd really like to have that reference if that's okay, because I'd like to.
Yeah, so I'll give it to you.
Actually, everyone's always known that it's been more.
Yeah.
I've always quoted 40%, but I've never had any.
Also, is it?
No, but I've never had any in the
Figures
lab.
for it.
The actual torque coming out or the amount of wattage coming out is
I get
actually
it.
this amount. So I'd quite like to read that qualitative on it.
And then we talked a little bit about DOMS for a while, and we were saying that actually, you know, in relation to ice baths post-training. They were saying actually if you are looking for, in the adaptive phase of your strengthening program, if you are actually looking for the hypertrophy, there's some good research coming out of saying that you actually shouldn't ice bath in the middle of your periodization where you are trying to gain strength and leaving it for your competition, because actually they're saying that you are reducing the adaptive phase of that hypertrophy gains off the dumps. Right. Again, they were very sketchy on the paper. I don't have the paper for that. It was just something that
what's done?
Nikki Phillips
I've got that.
there's something Nikki Phillips was saying that they were trying to look at a lot
You've got
more
the
areas that effect.
I've got that one on ice baths.
Do you? What does it say? Does it kind of like that?
It's about like the overcompensation of the muscle in training,
You're trying to gain that, so you don't
and it was to do with performance and their subjective feeling of DOMs, and like strength gains.
I'm
And
just getting
things.
that.
Yeah, it's quite good.
And then isotonic exercises, which are the most commonly used, constant muscle tension, functional, free weights, pulleys, weights. And then they talked a little bit about, this is again quite strength conditioning, but the different types of strength programs. Oxford McQueen, 1 rep max and what a 10 rep max is. So, do you remember these?
No, what is this? Before my grandpa was
Yeah. That's the other one. That's what their program is. That's the Oxford one. Again, I've never used that one before. And then you McQueen, 3 sets of 10. So that's kind of the three that they talk a lot about.
But you talk about reps, those are probably the 3 most important reps to work on. Yeah. You give them a patient, you probably don't do enough 1 hour and 10 hour.
Yeah, we don't assess that at all.
We should probably do that.
Yeah, we should. But how would we do it? Like, it's quite difficult here without the equipment. That's the thing. Unless you get them to do it in their own gyms and stuff like
Just
that.
one rep is maximum effort.
How would you assess it, like, weight-wise?
To quantify it.
How do you, yeah, how
The
you,
weight pushing or the weight lifting, weight carrying.
as in, like, kettlebells and stuff like that, rather than saying,
Oh yeah, you could do that.
yeah, I think it's something you probably don't assess 1 rep max enough. Then looking at the next, that's strengthening done, then we're on to assessing form and function. I'll just run through this quite quickly, this is quite short. Looking at how do you look at form and function, how do we assess functional movement. That's a link for the Cook and Burton's paper on pre-screening for pre-screening prior sport. It's quite a good one. They just cover squats, lunges. What else did I mention on squats, lunges?
Lunge rotation.
That's it.
Yeah.
So
Step up.
it's not a bad paper. I suppose, again, I think we do it here as it is. I think we definitely here look at form and function while we have people in the gym looking for that. Do we do it challenging enough, though, to highlight the impairments? So when we are assessing people's form and function, do we do it to a level where that is actually really, really challenging for them? And I think sometimes I do, but I think sometimes I probably don't go heavy enough and hard enough to actually really bring up the impairments. You know, so do we kind of look at all that sort of stuff? And again, should we spend more time doing the functional screening? Like, does everybody do functional screening in their assessments? So would everybody look at squats and lunges and gait and running? Do we all do that?
I usually just do maybe squat is the biggest one I always do.
Yeah.
most of the time.
I'm disappointed the answer is no.
Yeah. I think we do. I think we do it all here very well. We do single legs, double leg squats, and lunges. I think we all do look at that. I was the point I thought was most interesting is, do we do it challenging enough to really have it those impairments? And again, that's what we're assessing: posture, stability, strength, flexibility, and then video analysis. And now we have the video analysis from the ring downstairs. It's a really, really good tool to have back again to really look at the running assessments, which is quite nice. When you're looking at the form, got to obviously take into consideration all of these, if they're compensating, if they've got reduced stability, reduced strength, and why. Why are all those there? And that again was coming away with all the questions from the weekend is why. Why are they present? Have you found the cause? And are you addressing that cause then? And then last part, neuromuscular control and proprioception. And I think again we are really, really good at doing that here, looking at that. I'm going to kind of skip through this because I want to do something at the end, but these are your receptors for proprioception, so which is where we get it all from. I'm just going to skip on for a second. The evidence is very, very good for it, to say that with injuries there are neuromuscular deficits. I think there was a study done on ACL, ankle injuries and shoulder instabilities, and there is definitely a reduction in joint position, sense, balance after certain types of injuries. So it is a massive part of our rehabilitation. We have to cover it. looking at the training, you know, we have a lot of stuff here, Boxy Ball, you know, long boards. I think looking in the gym when people are training, I think we do cover a lot of the difficulties. We do look at, you know, people closing their eyes, we do, you know, shake people and push people, and I think we do kind of throw stuff at them. So I think we generally do cover this in most respects here with our clients. And when you're progressing in, this was, I found this really interesting, when we're progressing a skill, so we have ACL patient, for example, and we have them at a certain point, do we then progress them by looking at them under fatigue and then looking at their technique and their decision both under fatigue? And that's your end stage rehab. And I'm not sure, from my perspective, if I do the decision-making part under fatigue enough, or if I actually do it at all. The technique under fatigue, I think we do cover here, but I don't think I cover the decision-making part under fatigue. I'm not sure if we have the time with some of our appointments to do that. Maybe we do, maybe we need to focus it more. But I thought that was a really interesting point. Do we look at their decision-making under those fatigue situations? Because that has a massive influence on their skill and their return to sport.
You want to make that exercise at the end of the session.
Yeah,
So
exactly.
If you've got a short session, you still have time to do it.
Yeah. I don't think I would prioritise that. Anybody else agree or disagree with me on that one? I definitely haven't. And then when you're looking at the progression at that late stage, you know, again, we always look at our clinical tests, we always look at our strength, we do look at our functional tests like our single leg hop or whatever, but then do we look at the form as they fatigue? Can they multitask? And are they happy to modify the movement patterns in response to an external stimuli? So do we assess all that as a part of our clinical tests and strength in order to progress on in our late stages? So again, I thought that was just quite a nice highlight. And then we should probably bring in skill acquisition, motor learning principles, even with the less severe injuries. It doesn't have to be a massive injury, it can just be a very gentle grade 1 inversion sprain. We should be bringing all this in, regardless of the severity of the injury. And successful performance of an isolated functional task does not always reflect the true functional recovery involving multitasking. So somebody going up for a header in the gym here for football versus somebody going up for a header, you know, from a corner and last 30 seconds of a game. You know, can we recreate those situations here so that when the patient is on the pitch, have we actually covered those neuromuscular components? And again, I thought it was quite interesting. And that is it for now. That's part 1. Part 2 is yet to come. Any questions?
So you're saying that a few things there are quite interesting for you and you're not sure what you do or not. What's that changed since October in your treatment?
I definitely look at what I'm doing more under fatigue at those high level multitasking. So like I definitely would have always say somebody that knows about throwing balls and stuff, but do you do, you know, throwing balls and while you've got a third man trying to pull them, or are you just trying to just increase that load? I just think about it more. I just think about, you know, I still have a guy who's playing football at the moment, and I definitely am looking more at those last principles under fatigue, getting up here on the bungees, putting them around, really tiring them out, and then putting them on Boxy Ball. So I think it's just an awareness thing for me, definitely. That end stage, you know, tired, fatigue conditions, can they still perform a skill with precision? So I think it has changed my mentality of that.
In spinal rehab, one of the things that's really important is putting the patient in different stressful situations because recruitment patterns changes. So it's quite interesting that you'll take somebody to fatigue, and I can see absolutely why you would. In spinal, once you've got somebody working really well and you've got a nice pattern of recruitment and good strength, you then start asking them the most ridiculous questions so that they get so that they to see whether it's automatic, to see whether it's actually coming, and increasing their level of stress, which can be by making them do 7 other things to occupy their mind, or getting them to think about something totally different and see if it comes on.
So it doesn't always have to be practical, it can be mental as well.
Absolutely, yeah. And because you know that under those situations, the whole recruitment pattern changes, which there's no reason it shouldn't be the same for everywhere other than spinal, but we know that happens.
In spinal. On the course that weekend, I was on the Boxy Ball and I was on one leg and it was pretty alright. Then it made me do 5 times maths tables and I was all over the shop. It was really interesting. Like, as soon as I was trying to do 5 times maths tables while standing on one leg on a Boxy Ball, it was chaotic, absolutely chaotic.
That's a tough number by 5.
Yeah, that's the problem. I think it was just that maths. Any other questions? Does it make sense? Is it too basic? Does it make sense? And then your practical homework. So, what I want you to think about now is, I mean, still this might be still quite hard, but this is what we were sent away to do, is we were sent away to pick an exercise and try and apply some of that theory to that exercise, which is why I got you through the exercise at the start, and I want you to do it again. You can pick the same exercise, but I want you to think about if any of what we've talked about has changed your, the type of exercise you've chosen, or the reps, or the sets, or the position that you start in. Just curious to see if it changes. If it doesn't, it doesn't. That means you already know it. If it does, great, all better. So that's kind of your practical 4 now. And what I want you to do is I want you to give me back this, take a copy yourselves, and I want you to give me back one of these. I've written on the bottom as well that you need to consider like the agonists